Hi everyone, my name is Dr. Priti Anand, and today I'll be discussing some very important oncology questions with regard to your exam. Just starting with a small quote that stay focused and never give up. Okay, so this time in exam, there were many questions which were related to oncology and young generation, young people. So young people related cancers are majority of them are related to the cervix or the less with the ovaries, but yes, GCTs and borderline ovarian tumors can be. And endometrial, some questions were related to endometrial cancers also in the young population, and some related to endometrial hyperplasia. So I'll be covering everything which is related to the exam tested questions we are going to discuss today. So first question says it is related to cervical screening, that there is a primary screening where the HR-HPV test was positive and she underwent a cervical cytology where was a high grade changes were there. So she's a 35-year-old lady who is 30 weeks pregnant also. So what they did was, in the pregnancy she undergoes colposcopy today, and it gives us the diagnosis that it is SIN3 as a diagnosis. So what will be our further management for her? So because this patient is a young patient and a pregnant patient with SIN3 pathology, first thing you always have to remember that even colposcopy is done in pregnancy, and if it shows some changes, it always needs to be confirmed twice. Okay. So because she is already 30 weeks pregnant, so she has already crossed the second trimester. So now what we are going to do is we are going to repeat one more colposcopy postpartum so as to confirm our diagnosis first. Okay. Once it is confirmed, then we can do some excision procedure, but ever excision procedures are always done postpartum. Again, she seems to be the same patient, but I think yeah. So here she is 30 weeks pregnant and 35 years old. Again, the HPV was positive, cervical cytology was showing a high grade change, and they did a second colposcopy today. That means one colposcopy already done, which confirms that it was SIN3, and second colposcopy confirms that finding. Now, what do we do? As I told you, whatever you are doing as an excision procedure should always be done postpartum. Okay, even if it confirms SIN3, let the patient deliver first. Okay, so the answer over here is excision procedure postpartum. So the general concept for cervical screening in pregnancy is that the general cervical screening is never done in pregnancy. By chance, if the patient's cervical screening was done, there was an abnormality, and when she comes back to you, she gets pregnant, then colposcopy can be done in pregnancy. Okay. Now, colposcopy, whenever it is done in pregnancy, it should be done either in the late first trimester or early second trimester. Okay. Now, if the colposcopy shows the changes, okay, let's say SIN1 changes are there, you repeat colposcopy 3 months postpartum. But it is SIN2, SIN3 change. And if the colposcopy is done very early in pregnancy, like by the end of first trimester, you did it and it shows SIN2, SIN3, like a second colposcopy should be repeated by the end of second trimester. But as we have seen in the first question, she was already 30 weeks when the first colposcopy was done. So second colposcopy now will be done 3 months postpartum. So for SIN2 and SIN3 pathology, it is very important that you do 2 colposcopies to confirm your diagnosis. And once you confirm, the excision procedures are always done postpartum. Okay. Now, this is a lady who is not postmenopausal. She is a nullipara lady of 35 years old, and general practitioner has seen that 9 months of constant sensation of bloating and indigestion was there. Then they also found a pelvic mass on examination, so she was referred for a secondary care immediately. RMI was calculated because there was a suspicion of ovarian cancer and it was very high. So they are asking you that what is the further investigation you will do in this patient to do as a pre-invasive imaging to confirm and to see whether there is any metastasis or distance or close metastasis of the lesion. Okay. So because this patient has already been referred by a GP after calculating everything, RMI and everything. So now the next step in her management is CT scan of the abdomen and pelvis. Okay. So for the ovarian cancers, first of all, for ovarian malignancies, you have to calculate an RMI score. Okay. Once the risk malignancy index shows that it is a more than 200 score, which means that it is a high likely to be a ovarian cancer, you refer them to the onco center, but before that you always try to do a CT scan. So it is basically a CT scan and with the ongoing referral to the MDT care onco center. Okay. So here the patient will be referred to the onco center based on her report, based on her findings and based on her RMI scoring. Okay. Okay, so the next question is related to the most appropriate management step for the patients who suffer from cervical cancer. Now, because cervical cancer is a disease of young females, so majority you might find that they are still nullipara. Okay, but remember always cancers you can't leave just because she wants kids in future. So there will be some target, some borderline, some line we have to draw that after this stage we won't do a fertility preservation option, we won't give. Okay, so for cervical cancers, for until stage 1B1, till stage 1B1, you can offer them fertility preservation options. After that, you won't. They have to undergo the standard treatment. Okay. So let's see some questions. So it's a 30 years old nullipara, very anxious. Her recent HPV test was positive. So she underwent a cytology which showed the severe dyskaryosis. Colposcopy showed SYN3 changes. So what will be the further management for her? Okay. Now because SYN3 is something which needs an excisional procedure. So definitely she will undergo some sort of treatment, right? So what are we going to do? We are going to treat her with the see and treat leads procedure. Okay. For SYN3, which are related to the ectocervix, we always perform the leads operation. Okay. Okay, so the next question says that the young lady of 35 years old who has undergone a colposcopy directed biopsy confirms that it is SYN3 and leads was performed, and leads shows that it was not only SYN3 but there was some micro-invasive cancer changes up to the depth of 2 millimeter. Now when they have excised it all, they have clear margins. Okay. That means that it was in colposcopy, it was not confirmed that it was an invasion. It was a cancer. But on the leads histopathology, they confirm. But the lucky part is that whatever part they have removed, it is clear of margins. Okay. So for these patients, if the leads operation is done and the margins are clear, that means the treatment is complete. But definitely she will require a frequent follow-up with the HRHPV. Okay, so no further treatment for this patient. If you can see, the answer is C. No further treatment for this patient, but definitely she'll require a follow-up. Okay, now there is a 25 years old nullipara trying to conceive from 12 months. She underwent a cervical routine smear. There was a growth seen, so they referred her for biopsy for the growth. And the biopsy and everything and further investigations confirmed that it is a cervical cancer, and it is of 3.9 centimeters in size. Okay. Now for these patients, now if you understand this patient is still localized to cervix, but the size of the lesion is more less than equal to 4 centimeters, more than 2 centimeters. So it is stage 1B2 cancer. For stage 1B2 cancer, we can't offer them fertility preservation even if she's a nullipara. So we will do a standard treatment. So what is the standard treatment for stage 1B2? Because the size of the lesion is still less than 4 centimeters and she's still a young patient, so we can offer her radical surgery. Okay. Ideally, from stage 1B2 onwards, we give the chemoradiation therapy as a standard treatment. But for the young patients, because chemotherapy and radiotherapy completely destroys the sexual and the ovarian functions, what we can do is we can do a surgery for these patients, radical surgery. In case if there is anything problem in after the surgery, some size or lymphovascular space invasion, based on that, you can give the post-operative radio or chemo if required. Okay. Otherwise, usually the surgery can be a complete procedure for them. And because you are doing only surgery, so you are trying to preserve the ovaries. Okay. And because you are not using any sort of radiation and chemotherapy, if not required, we should not use. Surgery is enough, then it is good. But if they falls in the risk categories, then you should definitely provide them. Okay. Now the second question also, she is trying to get pregnant, nullipara, but here the size of the lesion is more than 4 centimeters. Still it is localized to the cervix. So it is more than 4 centimeters. So it is 1B3 cancer. What to do? Combined chemoradiation. Now there is a no chance of doing a surgery. Okay. So these are the answers for the question. So just in the short, I'll explain you the treatment protocol for cervical cancer. For very early stages cervical cancer, like stage 1A1, if the patient has family completed, the surgery, simple hysterectomy should be done. Okay. If she is not completed family, then you can do the leads operation. preferably. Leads or conization, but preferably conization. If it is not done earlier, then preferably conization. Stage 1A2, you can do hysterectomy and the pelvic lymph node dissection from this stage if the family is complete. If not, then you can offer these patients conization or radical trachelectomy. Similarly, for stage 1B1, you can do the surgery with pelvic lymph node dissection if she has already completed family. If not, then radical trachelectomy and lymph node dissection can be done. Beyond this stage, always combined chemoradiation is an option. But for the younger patients of less than 4 centimeters and good okay patient, then you can offer them surgery. But after every sort of surgery you are doing, you have to screen them. So for the high risk patients, if any of these risk factors present, you do after surgery, even she'll require chemoradio. And for intermediate risk factors, only radiotherapy after the surgery is required. Another very important aspect of cervical cancer is that because it is a disease of young patients, sometimes it is diagnosed in pregnancy also. So if a 35-year-old lady who is 32 weeks pregnant and is confirmed to have stage 1B1 cervical cancer in pregnancy, what to do? Now, because it is a 1B cancer and advanced pregnancy, we will just allow her to complete her pregnancy, but not till term. Okay, we will just allow her to complete till 34, 36 weeks. Fetal maturity is achieved. So not till term, not till 38 weeks. So first two options are incorrect. No chemoradiation, no radical trachelectomy for 1B1 at this stage. What you are going to do is you are going to deliver the patient and see if she has completed her family, do the radical surgery. Early, like stage 1A1, you can do some sort of conizations and radical trachelectomies between 14 to 20 weeks. But if it is an advanced stage cancer, first you have to see what part of pregnancy she is coming to you. For stage 1A2 and 1B1, if she comes very early, less than 22 weeks, you can do a pelvic lymph node dissection and check. If they are positive, you terminate the pregnancy. If negative, then you can either do a simple trachelectomy or delay the treatment after delivery. More than 22 weeks, always do not do pelvic lymph node dissection, either to give chemo or delay treatment. 1B2, less than 22 weeks, pelvic lymph node positive, terminate, negative, chemo or delay treatment. More than 22 weeks, chemo or delay treatment. And 1B3, less than 22 weeks, there is no pelvic lymph node dissection, but they suspect that there may be positivity, so they don't do it. So either you terminate or give chemotherapy, or more than 22 weeks, chemotherapy or delay treatment. Okay, so this is the basic concept for cervical cancer in pregnancy. Now, moving on to RMI calculation. So you all should know that how is RMI calculated. For the RMI calculation, menopausal status is first of all seen for ovarian cancers. Okay. Remember, the risk malignancy index is calculated for the ovarian cancers. So if the patient is premenopausal, we score them as 1. Postmenopausal, we score them as 3. On the basis of ultrasonic features, multiloculated, solid areas, bilaterality, ascites or metastasis if present. One feature, no feature, 0 score, one feature, 1 score, more than 1 score, score is 3. There is no score 2. Okay. And absolute value of CA125 is taken. So for risk stratification of ovarian cancer, let's see this question of RMI calculation. So for this patient who is a postmenopausal with the transvaginal ultrasound showing multiloculated cyst, solid areas, ascites, C125-200. So we can see that the postmenopausal score is 3. Ultrasound score is 3 because more than one features is present, and the absolute value of C125 is 200. So 3 into 3 is 9. 9 into 200 is 1800. Okay. So RMI score is 1800 over here. Okay, now let's see some questions which are related to ovarian cancer. In general, also we follow the same concept, and in the younger patients also we follow the same concept. Okay, so 46 years old lady who is diagnosed with cervical ovarian cancer, what is the appropriate management? So it is always a staging laparotomy, which is a standard treatment. Okay, so for any stage, because usually the ovarian cancer is diagnosed by the imagings and blood markers and everything. We never take a biopsy. So whenever we do a staging laparotomy, we do a biopsy. So it is the diagnostic and therapeutic. We remove all the disease which we can see. Okay. And for very early stage, we do not give adjuvant chemotherapy. But for the advanced stages, we give the chemotherapy post-operative. Let's see one staging question. So there was an ovarian cystectomy done for dermoid. Intraoperatively, everything was normal, but the cyst ruptured intraoperatively. Okay, So well-differentiated serous adenocarcinoma was confirmed and not extended to ovarian cancer. It was thought to be dermoid, but HPE showed that it was a serous cancer. Now, when the ovarian cancer is intact, located to one ovary, and the capsule is not ruptured or extending to the ovarian capsule, but the cyst ruptures intraoperatively, it becomes stage 1C. Okay, if you can see over here, we see that tumor is limited to one or both the ovaries. If there is an intraoperative rupture, surgical spill, then it becomes C1. It was already ruptured, C2, and if the malignant cells are present in ascites or positive washing, then it becomes C3. Okay. Now, very important. So, epithelial ovarian cancers are common in females, very common as compared to any other cancers. They can be seen in the younger population, but more commonly in younger patients are GCT tumor markers. So, we have one case. Now, we all know that we categorize or classify GCT tumor markers based on the tumor markers which are raised. Okay. So, there is an ovarian tumor in 13-year-old girl, and elevated AFP and lactate dehydrogenase is seen. So they are asking what is the likely type of ovarian cancer. So this question is related to the GCT tumors. So we all know that in younger population as compared to epithelial ovarian cancers, GCT tumors are more common. Okay, and they are diagnosed, they are classified on the basis of what type of tumor marker is raised. Okay. So if AFP and LDH is raised for a 13-year-old girl who has a solid ovarian tumor, so what will be your diagnosis? It is actually a case of yolk sac tumor. Okay, if you can see in this table, alpha fetoprotein is always raised with the yolk sac tumor. Okay, if you can see, only the place where alpha fetoprotein is increased is yolk sac tumor. And now they also say that LDH is increased in yolk sac tumors or endodermal sinus tumors. Similarly, if there is a patient who is 28 years old and 14 weeks pregnant, and significant past medical history, significant without a past medical history, treated for yolk sac tumor, which tumor markers are usually elevated in yolk sac tumor? So we have just seen alpha fetoprotein. Okay, this is one of the very important questions. Then there is a 12-year girl with the lower abdominal pain. Transabdominal ultrasound shows that is a bilateral ovarian tumors. Okay. So as I have already told you, for the younger population, GCT tumors are more common. And the one which is bilateral is usually a case of mature cystic teratoma, that is dermoids. Okay. So this is also something which can be seen in all these. The mature cystic teratoma is one which can be found as bilateral in the younger population. So this is a lady who is a 20 years old with the ovarian mass, and tumor marker shows that LDH is increased. Now you all know that LDH is released with the dysgerminoma, which is a kind of GCT tumor, and because she's a very young patient, so we have to definitely think all on the grounds of the fertility preservation surgery, right? So, one rule for ovarian cancers is whatever type of ovarian cancer you encounter, even if you're performing a fertility preservation, it's always a laparotomy. Okay, because we always need to see the whole abdomen. There is no distance metastasis. As I told you, surgical staging is a type of surgery which is both diagnostic and therapeutic. Okay, so we'll do a laparotomy 100% because one ovary is involved. So we do a unilateral salpingo-oophorectomy of that side. Biopsies will be taken, selective lymph nodes, if found to be enlarged, will be removed. But always remember, if the contralateral ovary is normal, we don't touch that ovary. Okay, so we'll do a laparotomy, unilateral oophorectomy, or mental biopsies, lymph node dissection if required, selective lymph node, not systematic, and we will definitely see if it's a very early stage cancer, the surgery is enough, and you can counsel her that she can get pregnant. Contralateral ovary should never be touched if it seems normal. If there is an abnormality, then we have to think, and the cancer surgeon will see what needs to be done next. Okay, so the next question says, as we have already discussed, that surgery is to be done 100%. Now, some patients in whom the surgery is, because they're very early stages cancer of GCT, so surgery is enough. But some patients, like stage 1C is an advanced stage, may require chemotherapy after the surgery. So for the younger girls, deep regime is used for the GCT tumor markers. Okay, for GCT tumors. So if the patient is less than 40, GCT tumors, you require deep regime, and 40 and above, you require the EP regime. Okay, so that you have to remember. Now, if you see to the flow chart, it says that very early stages cancer, you only do the fertility preservation surgery with no chemotherapy. But for the early stages GCT tumors, you always have to see for the surveillance. Okay, first 2 years is very crucial. So very strict surveillance is done for these patients to make sure that they are not reoccurring. Okay, so these are the group of patients in whom surgery has been done. No post-operative chemotherapy we have planned. Okay, because they are very early stages and you consider the surgery was complete. Now, moving to another set of ovarian tumors which are seen in younger population are borderline ovarian tumors. So they are not invasive cancers. So all of the following statements about the borderline ovarian tumors are true except. So BRCA gene mutations are not increased. True except. So we have to tell the false statement. Okay. So very true. There is no relation with BRCA genes. Surgical staging is a cornerstone. Yes. Lactation is found to be protective. Yes. Oral contraceptive is protective. No. And stromal invasion is not seen. That is also correct. Okay. So only thing which can protect us from the borderline ovarian tumors is ossiples. Okay. Like epithelial ovarian cancers, lactation is protective, but for borderline, it's not. So there is a patient who had an ovarian tumor and they have done the frozen section reporting and they say that it is a BOT. So they are saying what is not recommended. Okay. So appendicectomy, if it is a mucinous, you can do. Conservative surgery, yes. Total abdominal hysterectomy, bilateral salpingorectomy, if the fertility is not an issue, yes. Exploration of entire abdomen, yes. But macroscopically, normal ovary should never be touched. Okay, if you are planning a conservative surgery, don't touch it. Now, some questions which are related to the stages of borderline ovarian tumor. So, if it is a very early stage borderline ovarian tumor with no invasive implants and she desires future fertility. Okay, so for these patients, what do? We do a conservative fertility preservation surgery and close follow-up. Then who have advanced disease with invasive implants, then preferably we do a complete staging and cytoreductive surgery. Again, BOT who has completed the family, radical surgery, or we can say complete surgery, which is a cytoreductive surgery. And frozen section shows that it is a BOT. Final histology is awaited. So what is the most appropriate management? Better is to refer her for the cancer center. Okay. So actually the answer B, no, complete staging and cytoreductive surgery and radical surgery, they are the same options. So if you do not consider G, we can consider this option correct. More correct option will be B. That will do a complete surgery with the cytoreductive goals. Okay. So this is the one thing which you need to know. So for the borderline ovarian tumors, if it is diagnosed by chance or if it is diagnosed when you are doing a ovarian mass removal, considering that it is an endometriotic mass. Okay. Whenever you find BOT, you always make sure that the patient is handled in the cancer center. Now, if the fertility preservation is desired for the younger patients and early stages, do a conservative surgery with close follow-up. That is ultrasound every 3 months for 2 years, every 6 months for 2 years, and annually thereafter. Advanced stages, if there is no invasive implants, you can still go for the conservative surgery. But if there is an invasive implant or if the fertility is not an issue, always a surgical staging should be done. If the BOT is unresectable, then there is a role of chemo. Otherwise, there is no role. And as I have already told, any ovarian tumor, whether borderline GCT or epithelial ovarian cancer, anything, always you do a laparotomy. There is no scope, no role of laparoscopy. Okay. Now, another important thing is that some patients who are younger patients in whom there is a family history of ovarian cancer. Now, they come to you, okay, somebody has told me that because their family had ovarian cancer, their daughters had. Now, what is my risk? If I have a risk, what is my risk? How will I calculate my risk? So, the one thing which you can avoid, tell them is that you need a genetic screening, first of all. Now, if the genetic screening shows that it is a BRCA1 or BRCA2 mutation, you offer them risk-reducing surgery whenever their family is complete. Okay. So, BRCA, for these patients, we do risk-reducing bilateral salpingo-oophorectomy, preferably, okay, when it is done by the age when their family is complete. Preferably by 35, they should get it done. Okay. Now, one very important question which I would like to discuss is about the endometrial cancer. So endometrial cancer, one thing is that you have to very well know the staging for all the cancers. Now, if a patient has a very early stage endometrial cancer, like in this case, for example, MRI shows 3/4 of myometrial involvement, means it is stage 1B. Okay. Then they have done everything, all the surgery and everything, taken out the uterus, and now they confirm that it is low grade 1 tumor, 2/3 myometrium, negative lymph nodes. So what will be the post-operative management, post-operative adjuvant treatment? So it is always that some sort of radiotherapy is given to them. So it is post-operative vaginal brachytherapy which you give them. How do we see that how what to give to whom? So post-operatively, if the patient has stage 1A, grade 1, grade 2 tumor, then you give no treatment. If it's stage 1A, grade 3 or stage 1B, grade 1, grade 2, like in this case, you give brachytherapy only. And for advanced stages, you always give both EBRT, that is external beam radiotherapy, and VBT, that is vaginal brachytherapy. One more thing I would like to highlight now, because this patient, some patients are younger patients in endometrial cancer. So if it is a very early stage, stage 1A, grade 1, irrespective of age, you can do laparoscopy. Only this cancer provides us a help of laparoscopy. Okay. But if it is a younger patient, you can do laparoscopy, and even for less than 45, ovarian conservation can be planned. Some of the guidelines support that. Even the European oncology guidelines, though we are not reading it for our exam, for the exam we usually read a FIGO only. FIGO also mentions this, that less than 45, ovarian conservation can be planned. Okay. And after the surgeries from stage 1A, grade 2, you always do a laparotomy. And after the surgery, post-operative adjuvant treatment is planned. Also, I would like to focus on very important thing over here, that some patients who are very young and they are suspected to have endometrial cancer. Okay, what do we do? So what do we do? First of all, the essential criteria, if you are planning a fertility sparing management, because they are nullipara, is you have to very well confirm that it is a well differentiated cancer, that is grade 1 and limited to endometrium with no or minimal myometrial invasion. Okay, absence of lymphovascular space invasion, absence of extrauterine disease. Now, once you have confirmed, because some sort of biopsies you have done, but before offering them any sort of fertility preservation options, which are high dose progesterones, because you're not going to do surgery. Surgery is basically removal of uterus, then how will preserve the fertility, right? So what we are going to do as a fertility sparing option is a progesterone, high dose medroxyprogesterone acetate. But before doing, even if you have done a diagnostic hysteroscopy, always dilatation and curettage is recommended, even if hysteroscopy was already performed, before you offer them fertility preservation option of medroxyprogesterone. Okay, so these are few points which you should know, that the patient should be young, nullipara, less than 50% myometrium, grade 1, no lymphovascular space invasion, no distance metastasis, no lymph node metastasis, very well histopathologically proved by dilatation and curettage, and the option is medroxyprogesterone or megoestrol acetate, that is MA, in high doses. Okay, but they require frequent follow-up. If at 3 months, 6 months, you are doing a biopsy and they are positive, still positive, it is always better to do complete surgery. This was all about the cancers in the younger groups. How do you manage? Now, few things about the endometrial hyperplasia. So, endometrial hyperplasia, if it is diagnosed, two rules you have to follow. One is endometrial hyperplasia without atypia, and one is atypical hyperplasia. So, without atypia, always manage with LNG-IVs or oral progesterone. With atypia, irrespective of age, irrespective of nulliparity, you have to do the surgery. Okay, fertility preservation option is there, but if you ask me the standard treatment, it is always a surgery. So in this patient, if we see, they have not given the diagnosis, they have given the histopathological report that endometrial sample shows irregular, tightly packed glands with vesicular nuclei containing prominent nuclei. That means it is a atypical hyperplasia. She is a nullipara, but we can't do anything. It is an atypia. They would have asked what is a fertility preservation option of 47 years. Definitely, they won't ask you. But for younger patients, they might, and I'm going to discuss what to do in them. For this patient, what do we do? Nullipara is a risk factor for endometrial hyperplasia. What we'll do? We'll do a surgical option for that, and that is always a laparoscopic hysterectomy, but you can conserve the ovaries in premenopausal because she's a premenopausal lady, and for postmenopausal, because she's a premenopausal, you conserve the ovary but remove the tubes. Salpingectomy will be done bilaterally, but for postmenopausal, complete laparoscopic hysterectomy and bilateral salpingo-oophorectomy. Okay, now this is important. Now this is a 38 years old nullipara. Okay, and atypia is there. So I told you atypia always surgery is done, but she wants to preserve her fertility. She opted for medical management. What you can give best is to give her LNG IUS, but here the follow-up will be very frequent. Okay, 3 monthly you have to do a endometrial biopsy. So Mirena you can put, but at the same time, biopsies you need to do. And by the end of 1 year, you see every 3 months you will doing. By the end of 1 year, still there is a problem. Either ATP or hyperplasia without ATP, still is problem. No and normal endometrium. Please perform the surgery. Tell her to forget about her fertility. Okay. So whenever you are giving fertility preservation options, always screen them properly for CA125 and proper ultrasound. Make sure whenever you are giving fertility preservation option like LNG IUS or high dose oral progesterone for endometrial cancer, you always need to do a endometrial biopsies 3 monthly. Okay. Now, after for these patients with endometrial hyperplasia, whenever you are giving fertility preservation option, one negative biopsy, send her to ART center. Okay. Same is for endometrial cancer also. If you are doing high dose progesterone, one negative biopsy, send her to ART center for early conception. Now this patient is endometrial thickness 12 millimeter and it is simple endometrial hyperplasia without ETPR. So what you can do, you can give her LNG IUS in this case. So you can insert Mirena, but at the same time you do a biopsies to confirm to make sure that she is regressing. So you will do biopsy, but after 6 months. She is a PS of endometrial hyperplasia with atypia, but she opted for the conservative oral therapy, refused surgery. So what you did, you gave her oral progesterone. Now by the end of 12 months, she still shows some sort of hyperplasia without, it's from atypia, it is becomes without atypia, but hyperplasia is there. I told you, remember for 12 months, it should be normal endometrium. Okay. No hyperplasia should be there. So because she's still having an issue, we will offer her surgery. Okay. So we'll offer her hysterectomy because she's still having the changes by the end of 1 year. So this is the flow chart of endometrial hyperplasia, which shows that endometrial hyperplasia without TTP, you treat with the medical management, that is LNG-IOS or oral progesterone. You offer them every 6 monthly biopsies, and 2 negative biopsies, you can discharge them from follow-up. If the patient has a high BMI of more than 35, or if she is treated with oral progesterone, then after 2 negative biopsies, they have to undergo annual biopsies. Okay. And if the patient with atypical hyperplasia is you are seeing, then always offer them surgery. If you are giving them medical management for fertility or for purpose because they do not want surgery, then every 3 months you have to do biopsies. And after 2 negative biopsies, you do not discharge. You put them at 6 to 12 months follow-up of biopsies till they are ready for surgery. And for fertility purpose, after 1 negative biopsy, you have to send her to the ART. For atypical hyperplasia, the biopsies are done every 3 monthly. For without atypia, you do it 6 monthly. As I told you, if it is a surgical option for post any sort of hyperplasia, whether atypical or endometrial without atypia, for postmenopausal along with hysterectomy, you do bilateral salpingo-oophorectomy. For premenopausal with hysterectomy, you do bilateral salpingectomy. So thank you everybody. This is from my side. Hope this session helps you all. And for any doubt, you can definitely tag us in our YouTube channel, and I'll be really happy to help you all in clearing your exam with your doubts. Okay. So thank you so much, guys. Thank you so much, and good luck for your exams.